Hello, you are welcome to this video which seeks to address the burden of maternal mortality in Nigeria and Sub-Saharan Africa so that we can start to reduce the burden of maternal death or the prevalence of maternal death, and such that we can have a mother and a baby or babies alive and well at the end of pregnancy. When you read or hear in the social media or in the news media or print media, or even when a doctor talks about maternal mortality or maternal death, or a woman dying from pregnancy or childbirth, what readily comes to your mind? The WHO, World Health Organization, defines maternal mortality as the death of a woman while pregnant, during childbirth, or within 42 days of the termination of pregnancy, irrespective of the duration of pregnancy, irrespective of the site of pregnancy, from any cause related to the pregnancy or its management, but not from accidental or incidental causes. What the above definition or what the above statement means in effect is this: when a woman dies from any of the following. Number one, from pregnancy and its complications like malaria in pregnancy, anemia, pregnancy-induced hypertension, or eclampsia. Number two, from the termination of pregnancy, for example, with a case of abortion and its complication like post-abortal sepsis. Number three, it also means irrespective of the duration of pregnancy. That is to say, either pregnancy got to maturity or not. Number four, irrespective of the site of pregnancy. This is because most pregnancies will occur in the womb and the woman will have a normal pregnancy until its termination. But in other cases, she could have what is called an ectopic pregnancy, by which we mean this pregnancy occurs but didn't develop in the womb. And most especially, this develops in any of the fallopian tubes. Number five, from any cause that is related to or aggravated by pregnancy. For example, chronic hypertension. Chronic hypertension is when a woman is already diagnosed with hypertension before she becomes pregnant, or pregnancy-induced hypertension, again, as another example. The sixth talk about accidental or incidental causes. Accidental or incidental causes is not included in the case of a woman dying while pregnant. For example, a pregnant woman dying from a road traffic incident will not be counted as a case of maternal mortality. An estimated over 800 women are dying every day from the complications of pregnancy and childbirth. And for every woman that dies, there are some 20 other women that suffers from serious injury, infections, and disability. It has been documented that worldwide, about 99% of maternal deaths occurs in developing countries of the world. South Asia, Nigeria, and Sub-Saharan Africa as a whole falls into this category. And we see this occurring in rural communities and amongst the very poor people. What are the causes of maternal mortality or maternal death? We must realize that the causes of maternal death are the same anywhere in the world, either the underdeveloped nations of the world, the developing, or even the ones that fall into the category of the developed nations of the world. The causes of maternal death are the same, and these causes rank fairly in the same order. But let us see what are the very common causes of these deaths in our environment, in Nigeria and in Sub-Saharan Africa. I will read out some data or some statistics to us that shows us a true reflection of what happens amongst Black people. Number one and topping the list is what we call obstetric hemorrhage, commonly postpartum hemorrhage. This refers to severe bleeding after delivery, and it accounts for 23.7%. Number two is eclampsia. Eclampsia is a woman convulsing very late in pregnancy or during labor, and occasionally immediately after delivery. And this is usually in the presence of elevated blood pressure that is not controlled and excess amount of protein in urine. Usually, protein should not pass through the kidneys as the kidneys filter blood to produce urine. Protein shouldn't pass through them to be seen in urine. But in eclampsia, we see very elevated amounts of proteins. And eclampsia, which is number 2, accounts for 18.6% of maternal deaths. Puerperal sepsis. Puerperal sepsis simply means infection, especially bacterial infection following delivery. This accounts for 11.9%. 11.9%. Fourth on the list is obstructed labor or ruptured uterus. Obstructed labor means this woman is in labor, but for one reason or the other, the journey of the baby from the womb to the outside world becomes obstructed. And we've had cases also of rupture of the womb during labor. This accounts for 11.9%. 11.9% of maternal deaths. Number 5 is severe anemia or malaria in pregnancy. Anemia means low blood level. That is a reduction in the red blood cell count, or what we call the packed cell volume of anybody. So severe anemia or malaria accounts for 10.2%, on the average 10.2% of maternal deaths. HIV/AIDS accounts for an estimated 8.5%. Unsafe abortion accounts for 6.8%. Unsafe abortion 6.8%. Ruptured ectopic pregnancy. When an ectopic pregnancy ruptures and we don't have quick presentation to the hospital or prompt intervention, ruptured ectopic pregnancy accounts for 5.1%. 5.1% of maternal deaths. Diabetics accounts for 1.7%. Hepatitis accounts for 1.7%. 1.7%. Also, ranking very low is amniotic fluid embolism or pulmonary embolism, but this ranks very low as causes of maternal deaths. We must understand that women are key to the existence and future of any society. So we shouldn't have any risk factor, any cause, any complication, any reason that is good enough for any society, for any country to continue to allow for maternal deaths. Somebody once said, developing a country, developing a nation without attending to its women's health is like running off on a foot. And we know what that means. You cannot run on a foot. It's going to be very, very difficult. This would usually culminate in a country that continues to rank very high in the statistics of the world of maternal deaths. Hence, we must seek a way out. No woman should die giving birth. No woman should die giving life. So in seeking a way out and reducing the burden of maternal mortality in sub-Saharan Africa, we must identify the common causes which we just listed. We must also identify the factors that are responsible for these causes. We are going to discuss that very shortly. Then committees must be set up to develop strategies that would mitigate the prevalence or the incidence of maternal mortality in our environment. Apart from these strategies being put in place or being listed out, the political will on the part of government must also be there to ensure that these strategies are executed. And there should also be a monitoring, which is part of what government should do. There should be monitoring to ensure that there is an unwavering commitment to carrying out these strategies so that we would have very, very low, if not even non-existent maternal deaths. Now let us compare what maternal death looks like in the developing or underdeveloped world and in the developing nations of the world. For example, a research or a study that was carried out by some organizations that includes WHO, UNICEF, and the World Bank Group ranks Sierra Leone, Central African Republic, Chad, Nigeria, countries like Somalia very high on the list of maternal mortality. For example, Nigeria records over 800 maternal deaths per 100,000 for every 100,000 live births. Sierra Leone records about 1,300 maternal deaths or even more for every 100,000 live births. And in the developing world, countries like Finland, like Iceland, like Italy, like Greece, just average around 3 to 4 deaths per 100,000 live births. This disparity is much, and that is what will take us into considering what are the factors that are responsible for this wide gap, for this disparity between the developing and the developed nations. What are these factors? They include, but they are not limited to, non-availability of healthcare centers, standard healthcare facilities. Remember that we said that maternal deaths are highest in poorer communities in the developing world. In these communities, we have non-existence, non-availability of standard healthcare facilities. That is one. Number two, we have the non-availability or no presence of qualified healthcare practitioners that can manage pregnancies, delivery, and their possible complications. We have poverty and ignorance, lack of information. There is the usual saying that there is this circle of poverty, ignorance, and disease. But let me also say that there is the circle of poverty, ignorance, and maternal death. We also have the lack of good roads, accessibility to the cities where they can have these services rendered to them. During the rainy season, for example, there are going to be out of reach communities, either because there's a river that has overflown and these women are at a disadvantage because they cannot cross these flooded places to access quality obstetric practice. In these communities, we also have very poor referral system, traditional and cultural practices. We have very bad tradition concerning pregnancy and childbirth in the very rural communities of Africa. There are also some very bad religious beliefs against standard obstetric practice coming out from our churches, from our mosques, and from those who also practice traditional religion. Poor personal motivation is another factor. And again, early adolescent girl pregnancy or marriage is also another very disheartening factor. So having this endless list of factors enumerated, let us continue to have it at the back of our mind that essentially the goal of standard obstetric practice is to have mother and child alive and well, because it is not just enough to have a child without a mother. It is not enough to carry pregnancy to term and the baby dies. It is not enough to have both of them alive but not well. So what should the approach be to reducing the burden of maternal mortality in Nigeria and sub-Saharan Africa? Angella Musiimenta documented 16 ways to reduce maternal mortality, and I will read them out to us. Number 1, women must have access to skilled care before, during, and after birth. Before, during, and after they give birth. This is very, very important. Number 2, health providers must be trained in emergency obstetric practice. As long as you are a healthcare provider, especially if you are a clinician, if you are a nurse, if you are a midwife, she says must be trained in emergency obstetric practice. Not just obstetric practice, not just taking delivery, but in the emergency care of obstetrics. Health centers and clinics must have surgical supplies to handle complications. There must be surgical supplies to handle complications. Complications as common as postpartum hemorrhage, complications as common as trauma to the birth canal. There must be supplies. Drugs and equipment must be in place to handle these complications. Number 3, she said, maternal healthcare systems must be strengthened and communities mobilized and educated to improve deliveries in birth clinics. Communities must be mobilized and educated. Knowledge, they say, is power. Knowledge is power. Knowledge is potentially powerful. Ignorance is a killer. So communities must be mobilized and educated to improve deliveries in birth clinics. Number 4, skilled community-based birth attendants should be trained and posted to increase maternal coverage in remote areas. Most medical doctors would not want to go to the very remote areas of Nigeria. The current trend in medical and nursing practice today is a brain drain to UK, to Europe, and other developed nations of the world. So if we have a shortage of these professionals, what Angella Musiimenta is telling us is skilled community-based birth attendants. Birth attendants, yes, they may not be schooled in midwifery, in nursing, or as medical doctors, as obstetricians, but for those who are traditional birth attendants, she is suggesting that they must be trained. It means that the government must be involved. They must have some degree of professional training and posted to increase maternal coverage in remote areas. Number 5, give incentive to health providers to motivate them to do their job effectively. This is very important. For the few people, for the few professionals that would agree to go to these very rural areas, governments, non-governmental organizations, churches, religious organizations must endeavor to give some form of incentive for these people to help with maternal health. Number 6, contract with private organizations to deliver maternal healthcare services. This is very important. Contract with private organizations to deliver maternal healthcare services. These organizations may not even be healthcare organizations, but these are people that are women, that are men, that have female children, that have wives. People in these organizations should be contracted to deliver maternal healthcare service. They can sponsor these services in the hospital. This would ensure rural areas are covered and will reduce supply shortages, but attention must also be paid to the quality of services provided. Attention must be paid to the quality of services provided. As much as possible, we must have about the same service that will be given to the woman in the teaching hospital in the town or city, also given the same quality given to somebody in the rural area. Number 7, educate and empower women and girls about maternal health issues. This is very important. Every woman, every girl child must be educated about maternal health. Not just about the general health or hygiene practice, but about maternal health as it relates to pregnancy and delivery. Educate and empower women and girls about maternal health issue. They compose 2/3 of the world's illiterate and 70% of the world's poorest people. This is very shocking. Let me give it to us again. These women and girls compose 2/3 of the world's illiterates and 70% of the world's poorest people. Educated and empowered women can lead healthy lives and can lift their families out of disease. They usually marry later, and this is true. Those who have the opportunity to be educated will spend the good part of their early lives going to school, from primary school through to the university. So they would usually marry later and have fewer and elder children who are more likely to attend school. Number 8, empower women's group so they can deliver political success and tangible health outcomes. We need more women in the political space. We need more women in government. So women's group must be empowered so that they can deliver political success and tangible health outcomes. Number 9, launch professional, well-informed advocacy groups to call for action on maternal health. Launch professional, well-informed advocacy groups to call for action on maternal health. Implement streamlined and evidence-based maternal health interventions. Implement streamlined, not something generic. She said streamlined and evidence-based. These maternal health interventions must be evidence-based. We are doing this and it is not working. We are doing this and it is working. Evidence has shown that in following this particular line of practice in maternal health, we have better results. So this must be implemented as long as it is evidence-based. 11, implement evidence-based strategies to increase utilization of maternal health care services. Implement evidence-based strategies to increase utilization of maternal health care services. Number 12, remove user fees for maternal health care service and provide transportation services to maternal health care centers. This is a very funny one. We know that healthcare service, the delivery of healthcare service can be very, very, very expensive. But again, this is calling on the government. This is talking about political will. She says, remove user fees. Remove user fees for maternal healthcare services and provide transportation services to maternal healthcare centers. We've seen in the news media some 3-4 communities where women, in the very rural communities, where women will have to contribute money over a period of time to be able to buy maybe a tricycle or a rickety car to use as ambulance to convey women in labor from their communities to the nearest healthcare facility where standard obstetric care can be gotten. And they are doing this because of the burden of maternal deaths. Number 13, evaluate and monitor maternal and child health policies. It is not enough to do, there must be monitoring and evaluation so that there can be a betterment of these policies. So she says, evaluate and monitor maternal and healthcare policies. This is because there is always a room for improvement. Number 14, make sure that the appropriate government ministries are accountable to the public about the performance of investments in maternal health. Make sure that the appropriate government ministries are accountable to the public about the performance of investment in maternal health. The Federal Ministry of Health, parastatals like the National Primary Healthcare Development Agencies, they must be accountable to the public about the performance of these strategies, the implementation of these strategies, and investment in maternal health. Number 15, create strategic alliances between groups representing maternal health. This will open doors to political and financial support. Currently, maternal health communities have many leaders but no leadership. This is disheartening. Maternal health communities have many leaders but no leadership. We hope someday this would improve. Our last point, number 16, make child and maternal survival a core national and global health concern. This is a summary of it. This is a summary of it. Make child and maternal survival a core national and global health concern. Wow. Now, you would agree with me that theory would give us no results. It is in practice, it is in execution that we would have results. Again, we must remember that our aim at the end of pregnancy is to have mother and child alive and well. It is commonly said that nothing works until you and me work it out. Every woman must strive to be educated. Every mother must strive to educate not just a boy child, but a girl child. Every lady that is going into marriage must ensure that she has some knowledge about maternal health. This is very important. Every husband must have some knowledge about maternal health so that when they say your wife must deliver, or it is better that your wife delivers through a cesarean section, he is not running away. The government must play its part as individual, as corporate organizations, as religious body. We must also play our parts. In wedding ceremonies, the officiating minister, the officiating imam must take at least a minute out to encourage the new couple about maternal health. The need for antenatal care, they need to make sure that the woman is delivering in a standard hospital or in a facility that has the requirement for good obstetric care. This is very important. You would also play your part by clicking on the subscribe button, because in my next video, I'm going to be talking about childbirth, and I won't want you to miss out on this. I would also encourage you to share this video with every of your female friends, with every man that has a wife that has a sister, so that they won't miss out on this series of videos that talks about having a mother and a baby or babies alive and well. Until my next video, cheers. See you in the next one.